All right, I think we're going to get started here. My name is Dan Funk. We have Jake Yandre here as well, and Nick Olszewski. We're three AppyRT students, and today we're going to be presenting on inpatient management of immune checkpoint inhibitor toxicities, focusing primarily on the NCCN 2021 guidelines that came out recently. Objectives for this presentation are to identify the role of immune checkpoint inhibitors, recognize the incidence of their adverse effects, and monitor, identify, and manage adverse effects of ICPIs. So to start off with an intro here, before we get into the immune checkpoint inhibitors, let's talk first a little bit about the immune checkpoint. So this is basically a process by which your T cells surveil your normal cells in your body as well as the antigen-presenting cells to identify any tumor cells or virally infected cells. And they do this by binding the T cell receptor to the MHC class 1 on the membrane of the target cell. And normally, if a foreign antigen is found, the T cell will mount an immune response and proliferate to target that cell for destruction. However, there are a couple of regulatory interactions that can prevent this from occurring. So you can see on the left there, CTLA4 and CD80 interaction, as well as the interaction between PD1 and PDL1. These both downregulate the immune response. This is kind of a way of your immune system avoiding attacking your own cells. However, tumors can take advantage of this regulation and upregulate those markers in order to prevent detection by the immune system. So next slide. Good. So as you can see in panel A on the right, you have T cell binding to a foreign antigen and proliferating, mounting an immune response, no binding of PD1 and CTLA4. However, in the second image, you have a tumor cell who has upregulated that response, and the T cells are negatively modulated with no immune response. So the tumor is effectively escaping the immune system. Then in panel C, you can see our treatment with the immune checkpoint inhibitors is to disrupt this interaction with monoclonal antibodies. So there are three different targets that you can see on the left side: CTLA4, PD1, and PDL1, and different examples of medications that are associated with each mechanism. And by blocking that interaction, you end up with a similar response to panel A, where there's no binding and your T cells can proliferate and target an immune response against the tumor. And on this slide, this is just to demonstrate kind of the number of different indications that immune checkpoint inhibitors can be used for. So tumors kind of all throughout the body, because the mechanism is a little bit non-specific, it can be used for a variety of tumors. However, since you are upregulating the immune system in this case, you can have some autoimmune toxicities resulting from this. And this is kind of the underlying mechanism behind many of the toxicities we'll be talking about today.
So then the question is, why are we telling you this? Not everybody is an oncology pharmacist. However, the eligibility for using these medications is significantly increasing. In 2011, only 1.5% of cancer patients were eligible for these treatments. And as recent as 2018, 44% of cancer patients have now been eligible for this class of medications. Additionally, there's an increasing pipeline of these immune checkpoint inhibitors and a growing number of indications for the ones that are currently present. So then talking a little bit about the adverse events related to the immune checkpoint inhibitors, they can have immediate or delayed reactions. So even if only one dose of an ICPI is given, patients can present with a reaction months to years after that initial dose. Delayed reactions, however, are generally thought that they come within 3 months of ICPI treatment, but there are some outliers where it can be up to a year. Also, it's important to remember that the presence of toxicity shows that it is working. So although most clinicians commonly associate immune-related adverse effects with treatment-related toxicity, the presence of these adverse events also show that the immune system is sufficiently activated to additionally target the patient's cancer. So the goal is to try and manage that toxicity with the management of the cancers. again, emphasizing the importance of this topic, patients can present to the hospital or an inpatient unit at any time with ICPI toxicities, regardless of if an oncology pharmacist is present or not. So as pharmacists that may be staffing a PM shift or in the ED or any shift where a patient presents with an ICPI adverse event, it's important that we understand how to recognize and treat these immune-related adverse events. A little introduction to the timing and onset of the adverse events. On the top left here, we have ipilimumab, one of the immune checkpoint inhibitors, and we can see a little bit of the progression of the typical adverse events. So, for example, the skin rash often is the first sign of adverse event, followed by the colitis and others. And then you think that that's a little bit different for each agent. So the nivolumab shows that presence here. And then commonly treatments are combined, ipilimumab and nivolumab. So thinking about that has much more and longer and a little bit more excessive adverse events. So you can see that it shows in the graph here. So then moving forward, we can go through all of the different toxicities and how we'll treat them. Just a brief introduction to the myocardial, dermatologic, endocrine systems, the musculoskeletal, nervous system. GI is also an important one, and then we'll get to the bottom ones if there's time at the end. Here you can see our ICPI toxicity man. All of the different toxicities that we see from these immune checkpoint inhibitors are noted here, or at least some of them, to really emphasize the point that this is a whole body issue, all the different systems that are affected, and it's very impactful on the patient. So impactful that we send patients home with a wallet card to say, if you're experiencing any of these side effects, you should call your doctor.
Great. So now we're going to shift gears into the assessment, grading, and management of these toxicities. We'll be going through each of those body systems that Nick had mentioned and our approach to how we assess these, how we grade these, and then how we manage them. So as Dan said, we're pulling most of this information from the 2021, the September 2021 most recent NCCN guidelines for these related toxicities. And the grading is listed here. We grade them G1 through G4 based on G1 being mild and then G4 being life-threatening. So just so you are aware going into the grading system. So we're going to start our talk with myocardial toxicity. So the incidence of myocardial toxicity typically presents with myocarditis or pericarditis. It's an overall rare toxicity happening in only about 1% of patients. But the reason it's so important is it has a much higher mortality compared to the other toxicities, being 25 to 50%. This typically shows up roughly within 3 months of initiating the ICPI. So this table can be kind of intimidating. There's a lot of information to go through, but I'll do my best to try and summarize it. Going through a little bit of the signs and symptoms and the assessment, but really focusing on the management and what we can do for these toxicities. So patients who present with this, they're going to present with a typical heart issue that we would typically see in the ED. And our assessment is going to be that full cardio workup. And if we determine that the ICPI is what's causing the myocarditis, we're gonna approach it on the management in the top right. We're going to permanently discontinue the ICPI, and we're permanently discontinuing because of that high mortality rate. We're initiating high-dose steroids such as methylpred pulse dosing at 1 gram per day IV for 3 to 5 days, eventually switching to oral prednisone and tapering over 4 to 6 weeks. If there's no improvement in 24 hours on steroid treatment, we're going to add in immunosuppressive agents such as abatacept, mycophenolate, IVIG, infliximab, or ATG, depending on the patient population. If it's pericarditis, we're going to treat as our hospital guidelines relate. So we're determining, is it the ICPI that's causing this through our workup, and then we're discontinuing, starting steroids and adding agents as needed. So moving on to the dermatologic toxicities, the incidence for these is quite common. These are the most common toxicities. 90% of patients being treated with CTLA-4 inhibitors and 70% being treated with PD-1, PD-L1s end up with a rash or skin involvement. Typically that is a rash or itching, and the rash can really present in many different forms. Listed below are some of the more common. and some of the wide variety like vitiligo, like depigmentation, but maculopapular eruption, that tends to be the most common. And we'll go through each of these here in a moment. On the next slide, there's some examples of these in picture form, so if you are a little squeamish, just be aware. So on the left here, we have the maculopapular eruption. This is the most common type of rash. You can see it spread across his chest, stomach, and arms. On the far right, you have the psoriasiform eruption. That's like the psoriasis-looking lesions, which is another more common type of rash. And then in the center, we have the bullous dermatitis. This is a more rare form of the rash. It's almost blister-like, and it can happen anywhere across the body. And we'll be discussing the management of these coming up here. So starting with the most common, the maculopapular rash, we're really approaching this from how much the rash is covering the patient's body. So mild forms less than 10% of the patient's body, moderate 10 to 30% of the body surface area, and then severe greater than 30%. So with the mild forms, they may be with or without symptoms like itching, burning, or tightness. We're continuing immunotherapy. We're adding in a topical emollient. If they are having symptoms of itching, we can add in antihistamine. And then we're starting out with a moderate potency topical steroid. As we move up, we're covering more, the rash is covering more of the body, starting to limit activities of daily living. We're still continuing, still doing the same therapies we started with in G1, but now we're thinking about adding in oral prednisone at 0.5 mg per kg per day if they're unresponsive to the moderate topical steroid. And then finally, in the more severe cases, we're holding immunotherapy here. We're bumping up to high potency topical steroids, adding in oral prednisone 0.5 to 1 mg per kg per day, and then potentially bumping that up as needed. But there's this kind of pattern here throughout these that you'll tend to see. We'll start off with minor therapy, and then we'll continue to increase the aggressiveness of the steroid therapy as G1 goes through G4. So you might be asking, how do we approach figuring out how much the rash is taking up the patient's body? Here's the rules of nines. Many of you have probably seen this. It's how we grade burns and how we determine how much of the body is covered in burns. It's just a good tool to use if you're on the phone with a patient and talking to you about a rash. You can see there how the body's broken up by 9%. And then also a good rule of thumb is that your palm is 1% of your body is another way to grade. So moving on to itching or pruritus. This is approached the same way as the maculopapular rash. It's based on how intense the itching is and then how much of the body is covered. So in the mild localized areas, we're continuing ICPI treatment, adding in the oral antihistamine, and then starting with moderate potency topical steroids and potentially a lidocaine patch depending on how large the area is. As we move up to a larger area, potential skin changes at this point due to the itching. We're still continuing therapy, oral antihistamine, but we're adding in a gabapentinoid at this point for its anti-itch properties, and then upgrading to a high potency topical steroid. And then for that intense itching, it's covering the patient's body. They're having a tough time sleeping, tough time functioning. At this point, we're thinking about assessing IgE and histamine. We're continuing the previous treatment that the patients had prior, but now we're adding in oral steroids, prednisone, methylpred, 0.5 to 1 mg per kg per day. And then for refractory cases, we're thinking about adding in aprepitant or amiluzumab. And then depending on the assessment of the IgE and histamine, we can add in omalizumab as well. So now for the more rare types of rashes that patients may experience. For bullous dermatitis, which was that more blistery rash that we saw earlier, we're outright holding immunotherapy due to the severity of the rash. Patients less than 10% covering the surface area, holding, and then we're immediately going to high potency topical steroids as it covers more of the patient's body, continuing to hold, and then adding an oral methylprednisone or methylprednisone 0.5 to 1 mg per kg per day. And then if no improvement on that, we're adding in rituximab. And then if we're hitting greater than 30% body surface area, we're permanently discontinuing the ICPI. And then we're increasing the aggressiveness of increasing the dose of the oral steroids to 1 to 2 mg per kg per day, as well as adding in rituximab or IVIG if there's no response in 3 days. And then for completeness sake, I have Stevens-Johnson syndrome and then toxic epidural necrolysis, much more rare. But with these, we're permanently discontinuing, initiating those high-dose steroids, and then considering IVIG for these patients. Okay, so shifting gears, we're moving into the endocrine toxicities. The incidence for this is about 40% of patients. It can affect any of those organs that make up the endocrine system, the thyroid, adrenal, pituitary, and endocrine pancreas. Typically presents in about 6 months, and depending on the severity of the toxicity, it can be irreversible. So we're starting with the pancreas and hyperglycemia. Now, this can be difficult to nail down because there's so many different things that could potentially drive hyperglycemia. So we're really looking at it from the point of diabetic ketoacidosis. Does the patient have it or does the patient not have it? So patients with new onset hyperglycemia, or those with type 2 diabetes with low suspicion of DKA, or those with steroid-related hyperglycemia, we're continuing them on their therapy. We're monitoring their blood glucose, and we're approaching it from a diet and lifestyle change standpoint. Now, for patients who come in with that who are hyperglycemic with elevated blood glucose, and we have suspicion that they are experiencing diabetic ketoacidosis, we're going to do the full workup. If it's negative, we're going to manage them as we would above, we're continuing diet lifestyle changes, monitoring their blood glucose. But if they are positive with DKA, then we're going to hold until DKA is resolved, and then treat their DKA per our guidelines. So does the patient have DKA or not? If they don't, we can continue their therapy and manage them. If they do, solve the DKA issue while holding the ICPI and then restart it later. Okay, so shifting gears now to hypothyroidism and the thyroid gland. We have asymptomatic subclinical hypothyroidism and then clinical primary hypothyroidism. For each of these, we're monitoring the TSH every 4 to 6 weeks. And then we're basing our therapy on the TSH levels and the normal free T4 levels. So patients TSH between 4 and 10, we're continuing ICPI and just monitoring our TFTs. If that TSH starts to become more elevated beyond 10, we're continuing ICPI and then considering starting levo thyroxine at 1.6 mics per kg. And then depending on the patient factors is where we'll start that or not. And then with normal or low TSH with low T4, we're going to treat that per our central hypothyroidism, which we'll discuss here shortly. And then for clinical primary hypothyroidism, we're continuing ICPI and then initiating levothyroxine. So really approaching this, we're continuing ICPI therapy and then treating with levothyroxine as needed. So moving on to thyroid toxicosis, that's elevated thyroid hormone in the tissues. With this, we're going to be continuing ICPI if the patient's asymptomatic. We can consider adding in some symptom control like propranolol, atenolol, or metoprolol at this point, but it's often worth getting an endocrine consultation at this point. Often there's hypothyroidism as well in these patients, so treatment with thyroid replacement or hormone replacement is probably warranted as well. So moving on to the pituitary gland, we have hypophysitis. This is inflammation of the pituitary gland. This is a little bit more difficult to manage. At this point, it's probably worth getting endocrine consultation because we could be affecting any of our hormones at this point. So the workup will be focusing on all those hormones. We're holding the ICPI until symptoms resolve or we can get the appropriate hormone replacement initiated. And then basically, we're treating as needed or as for what's needed. If there's severe symptoms with concern for mass effect based on the inflammation of the pituitary, we can go to high-dose steroids listed there. But then, as mentioned, we're just filling gaps where needed based on what their labs show. So if there's pituitary damage, if there's second adrenal insufficiency, we can start hydrocortisone. If there's central hypothyroidism, we can go back and start hormone replacement therapy for the thyroid as well. So I have listed here primary adrenal insufficiency as well. It's typically not associated with ICPIs, but I have it on here just so it's on your radar. It is a possibility. It's rare, but it is a possibility. So moving on to fatigue. Fatigue is very common among patients on ICPIs. We grade based on the patient's ability to function in their everyday lives, their activities of daily living, and their self-care. If the patient has fatigue and they're relieved by rest, we consider that a G1. We continue immunotherapy. If their fatigue isn't being relieved by rest, this is a G2. It's starting to limit their activities of daily living. Depending on the patient, if they're okay with that, if they're able to manage it, we'll continue. And then we'll also think about trying a low-dose steroid at this point as well. Moving into G3 and G4, more severe, patients aren't being relieved. We're limiting their self-care. They're having a difficult time rolling out of bed in the morning. We'll consider holding or discontinuing the ICPI. And we're following up with these patients quite a bit. We do have our callback programs. We're talking to these patients regularly to really manage potential fatigue. Okay, moving on to GI toxicity. So GI toxicity usually presents as diarrhea or colitis. It's much more common in CTLA-4s as compared to the PD-1s. So roughly 30% of patients treated with ipilimumab experience this toxicity, and roughly 1 in 10 patients experience a grade 3 to 4 toxicity. It usually occurs within the first 6 weeks of initiation. So we basically approach this from 2 different standpoints. One, how severe is the diarrhea? How many bowel movements are they having a day as compared to their baseline? And then 2, is this caused by the ICPI, or is this a more infectious etiology? So with patients who have less than 4 bowel movements above baseline and they don't have symptoms of colitis, that's watery diarrhea, cramping, urgency, blood and mucus in the stool, we'll consider holding the ICPI, but we'll probably trial them with loperamide or Lomotil, Imodium and Lomotil for 2 to 3 days to see how that works. If there's no improvement, we'll think about starting an infectious workup. Hydration is another thing to really think about as well in these patients. So if a patient's having 4 to 6 bowel movements above baseline and they are starting to have colitis symptoms, it's not really necessarily affecting their activities of daily living, which I find interesting because 4 to 6 bowel movements above baseline is a lot. Hold ICPI, initiate steroids, 1 to 2 mg per kg per day of prednisone and methylpred until they reach back down to G1 or less. And that's IV preferred because of the motility and the absorption issues due to the colitis. And then as we move to greater than 6 bowel movements per day, we're discontinuing a CTLA-4 just due to the higher incidence of diarrhea. And then we'll consider resuming a PD-1, PD-L1, depending on if we can get them back down to their baseline. At G4, the more severe life-threatening cases, we're discontinuing. And then we're doing IV methylpred 1 to 2 mg per kg per day. And then we'll taper that over 4 to 6 weeks as they get back down to G1. But if there's no response in 2 to 3 days, then we'll consider adding in infliximab or vedolizumab. So moving on to hepatic toxicity. This usually presents as elevated transaminases and bilirubin. It occurs in about 5 to 10% of patients, and it's usually within the first 8 to 12 weeks of initiation. And it can happen with both of those classes, with both those mechanisms. So patients will come in with elevated liver enzymes, and we're really trying to figure out, is there something else that could potentially be causing this, or is this the ICPI? That's kind of the first approach. And then we base what we do, our management, on how elevated they are. So they're less than 3 times the upper limit of normal. We can consider holding, but we're going to be monitoring their transaminases more frequently. If we're getting 3 to 5 times the upper limit, we're holding therapy. We'll monitor more frequently, and then we'll consider adding in steroids, prednisone 0.5 to 1 mg per kg per day until we reach back down to G1. And then more severe and life-threatening, we're 5 to 20 times the upper limit or greater than 20 times the upper limit. We're holding and potentially discontinuing if it's greater than 20 times, initiating prednisone 1 to 2 mg per kg per day. And then if the patient's refractory, if they're not really having any effect from the steroid in the first few days, we're adding in mycophenolate. So overall, we're really focusing on how high above the upper normal limit are the transaminases, and then managing from there. So this same approach goes with the bilirubin, depending on the level of elevation. We're holding ICPI for 1 to 2 times upper limit of normal, initiating prednisone and methylpred 1 to 2 mg per kg per day, and then thinking about adding mycophenolate in as well. And then we're kind of following that same pattern with the 3 to 4 times the upper limit, but permanently discontinuing treatment at that point. Okay, so pancreatic toxicity. This usually presents as elevated serum amylase and lipase. It happens quite a bit, quite often patients will have this. And roughly 10 to 15% of patients will show up with a grade 3 or grade 4. However, most of these patients end up being asymptomatic and just have those amylase and lipase elevations. Acute pancreatitis with this is rare. So with the management in mind, we're basically trying to find out, does this patient have acute pancreatitis? So we're doing a acute pancreatitis workup. And if they do not, and they remain asymptomatic, our approach, no matter what the upper limit of, or no matter what the elevation of the lipase and amylase is, we're just continuing treatment. So no matter what their amylase and lipase is, if they're asymptomatic, continue treatment. If they do have acute pancreatitis, we manage the acute pancreatitis per our next slide. So with the workup for acute pancreatitis, if they're asymptomatic, but the CT finds that they do have acute pancreatitis, we can consider holding, depending on the elevation of the amylase and lipase at that point. And then also considering IV hydration. Now, if the patient starts to become symptomatic, we're going to hold the ICPI, continue with IV hydration, and then we're adding in prednisone and methylpred 0.5 to 1 mg per kg per day, treating till that we hit the lower G1 and then tapering over 4 to 6 weeks. And then in the more severe range, we're hitting life-threatening at this point. We're permanently discontinuing the ICPI, IV hydration, and then adding in methylpred as well.
All right, so moving on to the musculoskeletal toxicities. This is also a relatively common side effect. So patients present with arthritis or myalgias in up to 40% of patients, so a large minority. And can also present as polymyalgia rheumatica, or PMR, kind of presenting as pain and stiffness in the shoulder and hip joints, and also as giant cell arteritis, or inflammation of the carotid and temporal arteries. So you can see in the picture there, the temporal artery is showing through the skin. And this can present with headaches, jaw pain, vision loss, tongue necrosis, and other side effects. So our treatment for first inflammatory arthritis. So if the patient has just mild pain or only a small, one joint involved, we would want to continue the ICPI, manage pain and inflammation with NSAIDs kind of as our first line in the absence of contraindications, considering prednisone 10 to 20 milligrams daily if the NSAIDs are ineffective, and then consider an intra-articular steroid as well if it's just maybe one joint that's bothering the patient. We can also, for moderate, consider holding the ICPI. It becomes more bothersome for them. And then we'd be a little bit more aggressive with starting steroids, 0.5 mg per kg per day for 2 to 3 weeks. And then if there's no improvement there, or if the patient presents with kind of more severe presentation, joint erosions, or limitations on their ADLs, we would hold or permanently discontinue the ICPI, give prednisone or methylpred at a little bit of a higher dose, 1 mg per kg per day. And then if there's no improvement on steroids by week 2, we would consider our DMARD options. So we have kind of a lot of options available to us: infliximab, methotrexate, tocilizumab, sulfasalazine, azathioprine, adalimumab, etanercept, and hydroxychloroquine. Then the myalgias and myositis, or muscle weakness, that we alluded to earlier. In this case, after rheumatology workup for differential diagnosis, in the case of mild pain, we would consider holding the ICPI at that point and treating with NSAIDs kind of as indicated for that. And then for more moderate, severe, life-threatening kind of presentation, we would hold the ICPI, do higher dose steroids, prednisone 1 to 2 mg per kg per day, and treat pain as well with NSAIDs as above. At this point, we can consider IVIG as well to help manage. and some of those other DMARDs that we mentioned earlier, infliximab, rituximab, and mycophenolate, to manage the more life-threatening cases. Moving on to PMR and GCA, we talked about. These are really, or we're just presenting them together here on this slide. So for mild PMR, no limitations on ADLs. We would continue the ICPI, give prednisone 5 to 20 mg per day for 6 weeks, and then taper. For more moderate to severe PMR, in this case, patients would present with joint stiffness in their shoulders and hips and limits on their ADLs. We would hold the ICPI, give prednisone at higher doses, 10 to 30 mg per day, and taper over a longer period of time, 6 to 12 weeks. And then for GCA, we would hold the ICPI, give prednisone 1 mg per kg per day. And if the patient does have a visual presentation or it's impacting their vision, at this point, we would want to consider, high dose steroids, so pulsing 500 to 1,000 milligrams of methylprednisolone daily. And we can also consider methotrexate and tocilizumab for refractory or severe cases. Now, for nervous system toxicities, there are several different types of presentations for this as well. This does tend to be more of a rare presentation, but there are some isolated cases that have been reported in clinical trials. So one of the possible presentations is myasthenia gravis. So this is weakening of the skeletal muscles due to autoimmune attack of the neuromuscular junction. Guillain-Barré syndrome, which is a severe weakness due to an attack on the myelin of peripheral neurons that you can see in the image on the right, as well as peripheral neuropathy, aseptic meningitis, encephalitis, and transverse myelitis, or an autoimmune attack on the spinal cord myelin. So for myasthenia gravis, in this case, we would want to, regardless of the grade, it's immediately going to be a G2 through 4 if we diagnose the patient with this. And in any case, we want to permanently discontinue the ICPI if it presents this way. For management, we would do pyridostigmine, 30 milligrams 3 times daily, gradually titrate to 120 milligrams 4 times daily as tolerated to help manage that weakness. And then consider prednisone 20 milligrams daily. We really want to be careful in up-titrating this because the high-dose steroids can exacerbate the condition. So increasing by 5 milligrams every 3 to 5 days to a goal of 1 mg per kg per day, but no more than 100 milligrams daily. And then taper is able. For more severe cases, again, we're stopping the ICPI, giving methylprednisolone at a higher dose, 1 to 2 mg per kg per day, doing plasmapheresis or IVIG as well. And then if patients don't respond to plasmapheresis or IVIG, considering rituximab, and there's a couple different dosing regimens we can consider for that. And then another thing to note, as a pharmacist, avoiding medications that may exacerbate the condition. So like I said, high-dose steroids, beta blockers, ciprofloxacin, and IV magnesium. For Guillain-Barré syndrome, in this case, for, similar to the last case, there's no G1, it goes right to G2. For moderate presentation with some interference with ADLs and symptoms that are concerning to the patient, we'd really manage it the same as we would for a patient who's severe, and that might present kind of with limited self-care, weakness, progressing towards respiratory decline. And for management, we want to permanently discontinue the ICPI, IVIG or plasmapheresis right away, and then pulse dosing methylprednisolone 1 gram daily for 5 days, and then taper over 4 weeks. And then we can also give gabapentin, pregabalin, duloxetine for that neuropathic pain that may be associated with it. For peripheral neuropathy, in mild cases where symptoms aren't so concerning to the patient, we can consider holding the ICPI, potentially with a low threshold for holding it and monitoring symptoms going forward. For more moderate cases at this point, if it's interfering with their activities of daily living or if there's any cranial nerve involvement, we want to hold the ICPI, observe or start kind of low-dose steroids, 0.5 to 1 mg per kg per day, and taper. If there is progression, we'd want to initiate higher dose steroids, 2 to 4 mg per kg per day and taper. And then again, you can do gabapentin, pregabalin, or duloxetine for that neuropathic pain. For more severe cases, you would want to manage as we did for Yandre on the previous slide. For aseptic meningitis, we want to hold the ICPI if it's mild to moderate. If it's more severe, we're talking about stopping it altogether. And just because there may be some trouble with differential diagnosis, we might start IV acyclovir, 10 mg per kg every 8 hours IV until a PCR is obtained to rule out a viral etiology. And then once we rule out that etiology, we can consider doing steroids, prednisone 0.5 to 1 mg per kg per day, or methylprednisolone, higher dosing, moderate to severe. For encephalitis, management is really the same for any presentation. Hold the ICPI if it's mild, but discontinue for more severe. Considering acyclovir again for potential viral cause, and then higher dose steroids 1 to 2 mg per kg per day, methylprednisolone, and taper. And if severe symptoms present or symptoms are progressive, we can do pulse dosing as well, methylprednisolone 1 gram daily for 3 to 5 days, in addition to IVIG or plasmapheresis. And then if the patient does present with autoimmune encephalopathy antibody, we want to do rituximab potentially, or if they don't show improvement, rituximab. And then I think the last one we have here under the neurology kind of symptoms, we would want for the transverse myelitis, again, this is the kind of the spinal cord presentation, permanently discontinue the ICPI and do methylprednisolone pulse dosing 1 gram per day for 3 to 5 days, and strongly consider IVIG or plasmapheresis for these patients as well. All right. So next, we're going to talk about ocular toxicity. So this occurs, it's a very rare side effect relative to some of the other ones we've discussed, less than or equal to 1% of patients. But this generally just presents as inflammation of the various components of the eye. So uveitis and episcleritis are different components of the eye, as well as blepharitis, which is kind of inflammation of the eyelid. So for uveitis in mild cases, we would like to continue the ICPI, or we can hold and monitor for worsening symptoms and see how it progresses. For more severe cases, we would want to hold the ICPI and consult ophthalmology, and kind of under their guidance, start ophthalmic and systemic steroids until symptoms improve and taper over 4 to 6 weeks. If they have really refractory symptoms, we can consider some of the more extreme treatments, infliximab or methotrexate. And then episcleritis and blepharitis are treated the same, so I have them consolidated here. For mild cases, you can continue the ICPI and just start artificial tears to help manage their symptoms. And for more severe cases, holding the ICPI, and then again, consulting ophthalmology for starting ophthalmic and systemic steroids and taper over 4 to 6 weeks. Moving on to pulmonary toxicity. So this really has one presentation that we generally kind of lump together as pneumonitis. So the prevalence is somewhat rare, 3% of cases, but still out there. It can be potentially fatal in some patients, presents with dyspnea, cough, or it can be asymptomatic and just identified on imaging. And it can present greater than 1 year following ICPI initiation. So this is kind of one of those rare exceptions. And on the right, you can kind of see in the top images, patients who are on ICPIs, they have kind of those lighter pockets that show up on the imaging that disappear on the bottom after patients are initiated on corticosteroids. So treatment for pneumonitis for patients who are just kind of identified on routine imaging, we can consider holding the ICPI and reassess, but always kind of monitoring and seeing how that progresses if we do continue it. And And then for symptomatic cases, we want to hold the ICPI until return to G1 or less. And then starting higher dose steroids, prednisone or methylpred, 1 to 2 mg per kg per day, and taper. We can consider empirical broad spectrum antibiotics until we identify kind of the root cause of the pneumonitis, especially in these more severe symptomatic cases. And then for the severe and life-threatening cases where patients are going to be hospitalized for treatment, we would want to permanently stop the ICPI. Again, considering empirical broad spectrum antibiotics and giving methylprednisolone 1 to 2 mg per kg per day. May also add on infliximab, mycophenolate, IVIG, or cyclophosphamide to help manage those more severe presentations. And moving on to renal toxicity. So incidence in this case is about 1.5 to 5% of patients, so not totally uncommon. And this can present usually as an AKI that resembles acute tubulointerstitial nephritis. And the presentation is similar to what you might see in a patient with lupus nephritis because it does have a common autoimmune cause. And in this case, most patients do improve with steroids, so it's good to know. And then for more mild cases, if a patient presents with a mild AKI, we're looking at creatinine and how much that's increasing from their baseline. We can consider holding the ICPI, but we really want to kind of do that investigation into what might be another cause for any of these severities before we're making too many changes with things. And then consider consulting nephrology if things don't improve after 2 weeks. For more moderate cases, so creatinine is 2 to 3 times above baseline, holding the ICPI, consulting nephrology, doing lower dose prednisone, 0.5 to 1 mg per kg per day or equivalent. And then if there's no improvement, starting higher dose steroids with 2 mg per kg per day of prednisone or methylpred. For severe life-threatening, so this is creatinine greater than 3 times baseline or greater than 4 mg per deciliter, we can do dialysis in these patients, holding the ICPI, again, initiating prednisone and methylpred, that higher dose kind of right away in this more severe presentation. And we can also consider if patients don't improve on steroids after 4 to 6 weeks, some of those DMARDs, so azathioprine, cyclophosphamide, cyclosporin, infliximab, and mycophenolate.
Okay, that was a lot of information. So now we're hoping to kind of put that into some case to see if you were paying attention. So the first one we have here is a 44-year-old male who presents to the ED with itchy, burning rash covering about 15% of his body. And we bring this one forward because the rash is the highest incidence or highest adverse event, most prevalent in this case. The patient has a prior medical history of active melanoma, being treated by Keytruda or pembrolizumab every 3 weeks. The question for you all would be, what is the supportive treatment that you would recommend? Here are some options. So thinking about what you would do to treat this, moderate-sized rash that's burning for this patient on ICPI. We have a prednisone, lower but still high dosing, the highest, or the 1 mg per kg per day prednisone dosing, hydrocortisone ointment, fluticasone propionate, that moderate intensity, or just go straight to consulting dermatology. If you all wouldn't mind putting a letter or a drug name in the chat. So I see a couple C's, and that's not necessarily wrong, but Nikki has it right. It is D, the fluticasone propionate cream. So this is the moderately potent topical steroid. And if we look at back at the grading system here, with the 15% BSA and treatment has already surpassed the initial like low potency, moderate potency potency topical steroids. We're getting into the moderate potency topical steroids, and then later getting into the prednisone if unresponsive, which foreshadows our next question. The patient received that fluticasone propionate cream without improvement, and so they decided to start the prednisone 0.5 mg per kg, which is 35 mg per day. What supportive medications would you add based on this therapy change? And you can just give a free response in the chat if you'd like. So this one we didn't necessarily talk about, but just another reminder that we wanted to bring up here. Some of the things we were thinking about adding to this patient. Wonderful. Prophylaxis for infection. So yep, we did say the PJP prophylaxis would be a good thing to start with some Bactrim 3 times per week, as well as some acid control therapy for some prevention of gut irritation based on the prednisone and low immune system. So cephamotidine, usually 20 mg BID. We prefer this over the PPIs because there seem to be less interactions with the chemotherapy that these patients are on. Great. So then the patient has significantly improved on this prednisone, is getting ready for discharge. The team wrote to continue the prescription with an anticipated duration of 14 days. The question for the pharmacist was, how long should they taper the prednisone after the rash is improved? And this is also another free response you can add in the chat if you'd like. It was 35 milligrams. That helps you. Of prednisone. And since you're an astute pharmacist who looks at the guidelines, you can see that the taper should last about 4 to 6 weeks, considering. So as a final takeaway, I think if you learned nothing else from this presentation, I think it's important to say that immune checkpoint inhibitors are being used much more frequently and are being approved for more and more indications. And that being said, they are also very likely to cause toxicities. So we're also remembering that these toxicities can appear at any time, even up to a year or more after an initial dose of an immune checkpoint inhibitor. So remember that we can play an important role as pharmacists in recognizing these toxicities and recommending supportive treatment. And to do so, I would encourage the use of the resource that we based our presentation on today, the 2021 NCCN guideline of the management of immune therapy toxicities. And you can get access to this as a free login. Otherwise, you can use our slides with a lot of information on them. That being said, what questions do y'all have?